At ASH, we heard and saw a number of abstracts presented, in particular at the oral presentation sessions. And the overall message is that we are moving towards fixed duration treatment with either 2 or 3 drugs combination. What is not clear, and in particular during this ASH, from what we heard, is what is going to be the role of MRD. So minimal residual disease assessment is important. We are aiming at using MRD to drive our decision to increase the therapy, to combine more therapies, to stop the therapies earlier, depending on the level of MRD. But what we learn in these days at ASH is that we don't have to forget the genetic markers. So it is true that low level of minimal residual disease, undetectable minimal residual disease is predicting progression-free survival, but in the single patient there are still cases where you reach exactly the same level of death of minimal residual disease and still some will relapse earlier. And typically these are the patients with unmutated immunoglobulin genes or p53 mutation. So again, the same markers that still have a predictive value even in the era of chemo-free treatment when we are applying a fixed duration combination. So this is something probably that's the message that we have to take home from ASH. And another important piece of data that we will be seeing is the results of the ALPINE study. So with the second generation BTK inhibitor Zanubrutinib, that indeed showed, it confirmed actually a difference in progression-free survival and overall response compared to Ibrutinib in the relapsed refractory setting of patients with CLL. So this is again might be another player that comes to the market, and in particular that will be available to our patients.